Hello students, I'm the OG Guru. Welcome to the channel. In this very important video, we are going to discuss the most important PYQs for the upcoming FMGE examination. I'm here with a single agenda, single point mission to make OBGY your most scoring subject. But before that, do download the OG Guru app and do get in touch with me on this number for your personalized timetable and guidance for whatever exams it may be. Okay, so the first MCQ, Ventus application is contraindicated in. Now, anybody, Ventus is another word, vacuum. Okay, so they can ask you vacuum or Ventus is contraindicated in which of the following. So remember, my dear student, for instrumental deliveries, if we look at forceps vacuum, two things main. One, what are the indications? Sir, we can use it if there is maternal exhaustion. Okay, if the mother is exhausted, then yes, we can apply the instrument. Second, to cut short second stage of labor. Now, can anybody tell me which condition do I have to cut short second stage of labor? Yes, very, very important. Heart disease patient. Okay, why? Because heart disease patient, I don't want her to bear down. So heart disease patient, in a patient who, because while doing that bearing down effort, agar wo Valsalva, she's doing that Valsalva maneuver, she is likely to go in failure and complication. So heart disease patient, we can either apply a forceps or vacuum. Both are yes, accepted, allowed. And this, when we apply, this is called as prophylactic forceps. So as you know, we not only discuss one MCQ, lot of extra information I give you with every MCQ. So anybody, they can ask you, prophylactic forceps is applied in which condition? Sir, heart disease patient. Matlab, before there is any complication, you go and apply the forceps. So that is cut short second stage of labor. Or if already the mother is pushing too much, she is fully dilated for 2, 3, 4 hours, so prolong second stage of labor. Okay, so either cut short second stage, or if it's a prolonged second stage, then also I can apply the instrumentation. And of course, if there is fetal distress at full dilatation, the station is suitable, and even in fetal distress, when I want to quickly deliver the baby, yes, in fetal distress, forceps is preferred, because forceps is faster. Forceps is preferred over vacuum between the two, but vacuum can also be applied in fetal distress. The answer, very, very important. Please understand this. Prematurity is an absolute contraindication for vacuum. That means if the baby is 33, 34 weeks, 35 weeks, I will never apply vacuum. Why? Because, sir, if I apply vacuum, there will be increased risk of intraventricular hemorrhage in a preterm baby. So if in case in a preterm baby, forceps is okay, but vacuum becomes absolute contraindication. So please remember this, student, that if in the question paper they tell you that the patient is only 34 weeks of pregnancy, 33, 34 weeks, if the question is given to you and have to choose between the two instrument, what instrument? Yes, sir, forceps is okay. Vacuum is absolutely contraindicated because increased risk of intraventricular hemorrhage. Preterm babies are anyway more prone to intraventricular hemorrhage. Vacuum will cause more intraventricular hemorrhage. So I repeat, maternal exhaustion, yes, I can apply forceps vacuum. Heart disease to cut short second stage, or in case of prolonged second stage, fetal distress also. All these are my important indication. Preterm, absolutely contraindication for vacuum. And one more, remember, overall, my dear students, whether I apply forceps or vacuum, what about the pelvis? Yes, the pelvis should be adequate. That means there should be no CPD. Understood? Common sense, yes or no? Okay, sir, I'm applying an instrument and getting the baby out. I will only do it when I'm sure कि sir there is space for the baby to come out. अगर बेबी को बाहर आने के लिए जगह ही नहीं है, if it is CPD, cephalopelvic disproportion, then I will not apply any instrumentation. So remember this, that CPD, cephalopelvic disproportion, also becomes a contraindication for vacuum as well as forceps. Okay, so remember student that CPD should not be the CPD is cephalopelvic disproportion. CPD should not be there. There should be no CPD. Pelvis should be adequate. It is a prerequisite for any instrumental delivery. This is also a very important MCQ likely to be coming in the upcoming examination. Okay, and my dear students, stay right till the very end because we are going to discuss very important images in the end, and with one MCQ we are going to discuss 3 to 4 image based MCQ towards the end of this video. So stay right till the very end. Okay, now very important, nulli gravida patient, okay, nulliparous patient, third degree prolapse, that means she has not yet any babies till now, and there is no rectocele cystocele. What is the surgery for choice? Now, if in a young patient, 24-year-old nulli gravida patient, if I do a hysterectomy, we have to go to jail. Yes or no? We have to go to jail if I do a hysterectomy in a 24-year-old. Is it clear? Similarly, my dear students, Leaford surgery is only for postmenopausal ladies. Okay, only for post MP matlab post menopause. Why? Because in that we suture the vagina. That is only done so that when the patient is not fit for surgery. So if I have an old patient, very old patient, and who is not fit for surgery, details I explain in my detailed lectures. Right now, just remember that Leaford surgery is done only for a postmenopausal lady. We colpo means vagina, clysis means fusion or suturing. So we suture the vagina so that we prevent the prolapse from happening. But most important, only when the patient is not fit, then we do that surgery. Not fit from the anesthesia point of view. So that is also out. And my dear student, again one more MCQ, clap if you feel happy. Why will I not do a Fothergill surgery? Very important. Can you tell me what is the main step of Fothergill surgery? The main step of Fothergill surgery is, yes, cervical amputation. Please by heart this. Cervix bahar aaya hai. Chop off the cervix. So when we chop off the cervix, what can happen? Yes, sir. Either the cervix can undergo cervical stenosis. Cervix becomes too tight, the remaining cervix or the new cervix, and that can lead to infertility. So patient is not able to conceive. Or if she conceives during labor, there is a risk of dystocia, cervical dystocia. And more importantly, anybody? Yes, sir. What can happen? Cervical incompetence. Surely coming in this exam. And if there is cervical incompetence, what can the patient have? Yes, sir. Repeated painless second trimester abortions or even risk of preterm labor, etc. But mainly cervical incompetence would lead to repeated second trimester abortions. Okay, so you can see that, sir, either the patient is not able to conceive only, infertility, or if she conceives, she can land up with repeated second trimester abortions, preterm labor, all this complication. So for this so many complications, Fothergill operation is also almost today not done nowadays or never to be done in a nulliparous patient. When the family, nulliparous means she wants babies in the future, she has not yet had any babies till now. And therefore remember what is the dictum 15-20 years back. Akshay Kumar, Katrina Kaif movie had come, Singh is king. Yes or no? Repeat after me, all my dear students. Singh is king, Singh is king, Singh is king movie had come, and all of you will remember Sling is king. Okay, sling is king का मतलब है sling is the best surgery. It is done through the abdominal route, so we call it as abdominal sling surgery. So कैसे याद रखना है? Sling is king मतलब sling is the best. Also known as cervicopexy. Okay, so if this is not in the exam, don't get confused. Cervicopexy, another name is sling surgery, abdominal sling surgery. All are Indian contribution. Purandare sling, Shirodkar sling, Khanna sling, Virkud sling. So names of the sling surgery are not expected at your level. आपको खाली याद रखना है sling is king. That means sling is the best, and that is the best option for a young patient who has never conceived and planning for pregnancy in the future. Sling surgery or cervicopexy. Sling is king, sing is king. Okay, moving on to the next very important MCQ. Many students get confused. What is this tandem radiotherapy? So please understand this, that in radiotherapy, one is a teletherapy. This your radiation teacher will explain to you. Teletherapy मतलब from external beam, दूर से radiation देते हैं, and one is brachytherapy. Okay, that means from close to the organ. So we use tandem, and there is also ovoids. So radioactive. So tandem is a small tube inserted inside the uterus, and ovoids are kept in the vagina. And this is the kind of treatment which we give for cervical cancer. Which stages of cervical cancer? You should know that, sir, only my stages 1A to 1B, 2A are operable. Beyond stages 2B, okay, stage 2B, stage 3 and stage 4, 3A, 3B understood, 4A, 4B understood. Sir, all these stages of cervical cancer are not operable, and we give them only CTRT. CTRT matlab concurrent chemoradiation. What is the meaning of concurrent chemoradiation? Sir, cisplatin is given first, cisplatin plus radiotherapy. So in this radiotherapy, this tandem and ovoids, basically tandem and ovoids, are inserted in the near the patient cervix and in the vagina, and then a radiation is given to the patient so that it will not damage any other organ. Okay, so cervical cancer is the one where tandem, and even if the word ovoid is used, okay, so inside the tandem and ovoid you charge them with radioactive material, it is a part of your brachytherapy. Brachyradiotherapy. So we use the word only radiotherapy, or nowadays word used is CTRT, concurrent chemoradiation, cisplatin plus radiotherapy. For which stages of cervical cancer? So stages 2B, 3 and 4, all these stages. Okay, ovarian cancer, we prefer surgery followed by chemotherapy. Endometrial cancer is surgery followed by radiotherapy, and choriocarcinoma is only by chemotherapy. Okay, but cervical cancer, tandem and ovoids radiotherapy is given. Just extra thing, if you want to know, okay, when I put this radioactive material inside the patient, the dose is basically directed at point A and point B. Okay, so this is the outdated MCQ, अभी कोई पूछने नहीं वाला है, but at point A and point B, point A is 2 cm above and 2 cm lateral to the external os, and point B 2 cm above and 5 cm lateral. Okay, so all this I am not going to ask you, but at point A we have the paracervical lymph node or the parametrial lymph node, and at point B we have the obturator lymph node. So this is बहुत पुराने साल पहले 2010, 11, 12 में ये MCQ आया था. Point A and point B used in radiotherapy are with which cancer? Same option, cervix, uterus, ovary. Answer is cervical cancer. Okay, point A, point B are 2 points where we focus the radiation by putting this tandem and the ovoids. Okay, so tandem, ovoid, cervical cancer. Young woman wants to take post-coital contraceptive pill, also known as emergency contraception. Which one should I give? Yes, all of you should get this correct. Surely repeated. Famous क्या है? Brand name are not going to be asked to you, but I-pill. I-pill is एक ही गोली, and this single tablet is 1.5 milligram levonorgestrel. So if they ask you the most common or preferred LNG tablet, 1.5 milligram single tablet. And anybody, what is the emergency window? Yes, within 72 hours. Only estrogen we do not give, norethistron does not work, and estrogen progesterone becomes like your OC pill that will be required to give in very high doses. So that is not preferred. Okay, only OC pills you can give, but then it's like 4 tablets together, 4 after 12 hours. So a lot of tablets required to be given. So that is not preferred. Preferred one or the best one when the patient comes in the first 72 hours, remember LNG only pill or single tablet ek hi goli, which is your I pill. Okay. If the patient comes in later, anybody, if the patient comes on the 4th day or 5th day of unprotected intercourse, then what are the options available? Anybody? Yes, sir. Then we can go for IUCD insertion. We are discussing about emergency contraception. And then a newer drug. Clap if you have learned something new. Ulipristal. Ulipristal acetate. It is a selective progesterone receptor modulator, 30 milligram stat. So lot of high yield gain. My guarantee, even when the students walked out of the last 3-4 INICET, NEET, PG, and specifically FMGE exam, they all called me and told me, sir, all my MCQs in my paper were from your lectures only. And I can assure you, same thing will happen when you walk out on the 12th of January. When you will listen to all my video lectures, you will message me that, sir, among all 19 subjects, my best performance was in OBGY. So please do not waste your time. Quickly download the OGGURU app. Exciting offers I'm going to tell you, and get in touch with me on this phone number for timetable and guidance. And do share this video with all your friends and colleagues also. So coming back, 30 milligram stat or the single dose is ulipristal, that can also be used as emergency contraception if the patient comes on 4th or the 5th day. But if they ask you, the patient wants among this option, LNG is the best, and remember the emergency window is 72 hours. Okay, moving on to the next MCQ. Yes, very important. At 11 weeks of gestation, she either underwent abortion or an MTP. She is Rh negative. Partner is Rh positive. Do we give anti-D or not? Many students don't know this concept. Now please understand this, that whenever we are giving anti-D injection, when do we give it? Sir, if the mother is Rh negative, the father or the husband or the partner is Rh positive, then only there's a point of giving. And remember one more important criteria. When I am going to give this anti-D, the ICT, the indirect Coombs test, should be negative in the mother. Mother ka ICT should be negative. Then only is a point of giving the anti-D injection. Okay, why? Because please understand this, that the anti-D is to prevent antibody formation or prevent maternal isoimmunization or prevent maternal antibody formation. So ICT negative tells me that mother is not yet sensitized. If the ICT is positive, indirect Coombs test is positive, there is no point giving anti-D. So here also in the question paper, actually they should mention that mother's ICT is negative, but you assume it. Why? Because please write down, if the ICT is positive, if the indirect Coombs test is positive, then there is no role or no point of giving anti-D. Okay, is it understood to all of you? Now remember, my dear students, after delivery, okay, after birth of a baby, after a newborn is born, after delivery, we will check the baby's blood group. And if the baby is Rh positive, after delivery of a Rh positive baby, here we give full dose, 300. So 300 microgram is after delivery. Is this understood to all of you? After delivery or after birth of a, of course, Rh positive baby. Okay, because if the baby is Rh negative, then again anti-D is not required. But now anything in the first trimester, 11 weeks matlab first trimester. Now please understand, this is based on the assumption that the baby which I suck out in MTP is Rh positive. Okay, because prevention is better than cure. So you have to assume, because जो बेबी हम एमटीपी में सक आउट करेंगे या जो अबॉर्शन हो गया, इज इट पॉसिबल टू डू इट्स ब्लड ग्रुप? नो. आफ्टर द बेबी हु इज बॉर्न, आफ्टर द बेबी डिलीवरी हम बेबी का ब्लड ग्रुप कर सकते हैं. एंड इफ द बेबी इज RH पॉजिटिव, I will give anti-D. So whenever if it is either a MTP or a ectopic pregnancy or even a miscarriage or abortion, if the patient is in the first trimester, you assume that the fetus is Rh positive and 50 microgram. Please remember this. Anything in the first trimester, 50 microgram is the dose of anti-D which we will give. Is this crystal clear, my dear student? I repeat that, sir, baby born हो गया तो 300 microgram देंगे if the baby is RH positive. I will do the baby's blood group. But if it is a ectopic pregnancy or MTP or abortion in a RH negative patient, I assume that the fetus was RH positive, and to prevent, because prevention is better than cure, even after abortion, MTP, ectopic pregnancy, anything in the first trimester, agar patient hai, 50 microgram anti-D has to be given. Okay, not this ke anti-D is not required. Okay, anti-D is not required only if the ICT is positive. That means mother is already sensitized. Okay, so I repeat, remember 3 criteria. Mother should be RH negative. Of course, the father or the partner or husband should be RH positive, and mother ka ICT should be negative. After delivery, 300 dose hai. Anything in the first trimester, 50 microgram is the dose. Second trimester onwards, second trimester ectopic है, at 28 weeks routine. Last trimester any complication feto-maternal, then again 300 microgram. So दो ही dose याद रखना है. Anything in the first trimester 50, after that 300 microgram. Okay, very important. Now I'm so happy I teach this every year, and this was also one of the PYQs for failure of contraception. Now all of you know new guidelines. They will say, sir, new guidelines, MTP allowed till 24 weeks and directly mark 24. No, please understand this, that yes, the rules of 20 MTP was allowed till 20 weeks, and now MTP is allowed till 24 weeks, but for which condition? Yes, this 20 to 24 weeks limit has been increased for fetal anomaly, because remember, my dear student, sometimes the anomaly was detected at 21 weeks, 22 weeks. So if there's any fetal anomaly or any genetic or chromosomal problem in the baby, then till 24 weeks we can do that. Similarly, if of course mother's life is at risk, and specifically for sexual assault victim, rape victims, because they might be delayed in coming out and telling, and when the pregnancy is detected, pregnancy might automatically be 21, 22 weeks. So if the rape victim comes on late. So please understand this, 20 tak tha, 24 tak increase kiya hai for special categories like fetal anomalies, genetic problem, rape, danger to the life of the mother. Please understand, for FC, FC matlab for failure of contraception, MTP can still only be done up to 20 weeks. Please keep this in mind. Okay, if your condom has ruptured or torn, you can't be sitting at home till 24 weeks. Okay, remember, dear students, so for failure of contraception, still only old rule is applicable, old criteria of 20 weeks. 24 weeks limit is increased for rape victim, sexual assault victim, genetic problem, chromosomal anomaly in the baby detected. Is it clear to all of you? Very likely to be repeated याद रखना ये. And very similar question, I have kept it back to back so that again ये point एकदम perfectly आपके दिमाग में छप जाएगा, permanently goes in your brain. 22 weeks पे patient has come with failure of contraception, requesting MTP. What can be done? Can I do? Sorry, sir, wrong. I cannot do. Even if 2 doctors, 10 doctors, because sir, failure of OC pill failure is failure of contraception. Patient is already 22 weeks. Failure of contraception, the MTP is only till 20 weeks. Okay, after permission of the hospital, superintendent, medical board, no. Yes, answer is can be done only if I find a congenital anomaly in the fetus, because sir, for 20 to 24 weeks the new guideline is there if there is any anomaly in the fetus. Is this understood? So that is the answer. Okay, sir, if there's any anomaly in the baby, then we can do it. Otherwise, sorry, at 22 weeks for failure of contraception purely, MTP cannot be done. Please keep this in mind. Moving on to the next MCQ, POPQ system. Very important. It was a previous year question, difficult MCQ, likely to be repeated. My dear students, POPQ is pelvic organ prolapse quantification. Q stands for quantification. So it's a newer way how we classify the prolapse. And POPQ system, remember another name which is very likely, it even came in the NEET PG, grid system or grid classification. Okay, like this a grid is made, there are 9 points. Okay, like how आपका x and 0 होता है, so there are 9 specific readings are taken, 9 readings. So this is also called as grid classification or a grid system, or grid classification is nothing but another name for POPQ. Details you are not expected to remember. In this, only important point what you remember is that hymen is the reference point. Please by heart this, because in here all the readings are taken. How much is the prolapse above the hymen, how much is the prolapse coming out below the hymen. So hymen is the reference point. So very new MCQ, remember POPQ, pelvic organ prolapse quantification, also called as grid system or grid classification. Agar name aaya, all mean the same thing. Hymen is the reference point in this classification. POPQ is pelvic organ prolapse quantification. Details are not expected. Just remember it's a newer way of quantifying how much is the prolapse based on the prolapse with reference to hymen as the reference point. Okay, moving on, very important. Now whenever it is a ovarian torsion, what happens? Please pay attention. The pedicle gets twisted. The pedicle will be there. The mass, the ovarian cyst or ovarian mass will be there. By the way, one more MCQ. Can anybody tell me, clap if you feel happy, which among all the ovarian cyst, which has got a highest risk of torsion? Anybody? Yes. Dermoid cyst, my dear student, is the most common or maximum risk of undergoing a torsion. Maximum risk of torsion, a dermoid cyst. So whenever जब भी torsion होता है, you know कि the cyst or a tumor twists. That's a torsion. So the blood supply gets cut off, because जब ऐसा twist हो जाता है, the blood supply will get occluded, and that is why for torsion we have to look at color Doppler. Remember simple rule, my dear student, कभी भी कहीं पे भी आपको blood supply देखना है तो color Doppler. Example DVT, color Doppler. ectopic pregnancy, ring of fire, color Doppler. IUGR, बेबी को कितना ब्लड मिल रहा है, color Doppler. So all that is color Doppler, and therefore your MRI CT scan will only tell me how big, how small is the mass or the tumor, but torsion है कि नहीं only comes with simple sonography in sonography color Doppler. So USG color Doppler or color Doppler is the answer or investigation of choice. Then laparoscopy is the final surgery. Yes, today nowadays, so the treatment is immediately surgery. The treatment is immediate surgery. Olden days laparotomy was done. Nowadays laparoscopic surgery is done. So laparoscopy you do after you confirm that it is a torsion. So don't directly go for laparoscopy. The investigation which you do is ultrasonography color Doppler. MCQ repeat hoga surely. Laparoscopy is then finally in the treatment and in the management you have to do. You detort it and see it. You can remove the cyst and save the ovary. Okay, so basically when the torsion happens, the pedicle twist, the blood supply gets occluded, and therefore excuse me, we are wanting to look at the blood supply and blood vessel, and therefore we can come to know only by color Doppler. Moving on to the next very important MCQ. डायरेक्टली स्टूडेंट पढ़ते हैं अल्ट्रासोनोग्राफी प्लासेंटा नियर द सर्विक्स. सर इट इज प्लासेंटा प्रीविया एंड आई विल डू सिजेरियन सेक्शन. नो, रुको, ध्यान से पढ़ो. इट इज ओनली 20 वीक्स. एट 20 वीक्स many times we do a scan and the placenta is low lying or even covering the os or near the os. Okay, what happens is that because it's a small uterus, the baby is there. This is the os. The placenta may be here and it can come in front of the presenting part like this at 18-20 weeks. Now what happens majority of the time as the uterus grows, upper segment keeps on growing more and more. So most of the time the placenta, it's not that placenta पूरा नीचे से निकलेगा, it will walk across the uterus और फिर ऊपर जाके fit हो जाएगा. No, the placenta gets pulled upwards, and therefore most of the time when I will repeat the scan in the third trimester at around 32 to 34 weeks, the placenta will have migrated upwards. Okay, so please remember this, that when the placenta is, it's like a breech. Like if you feel the breech is at 18-20 weeks, we don't make the diagnosis. Then breech, we wait, baby can spontaneously rotate. Same logic for breech also. Same logic for low-lying placenta also. That most of the time at 32 weeks or in the third trimester, 32, 34, even 36 weeks, we repeat the scan, the placenta will go up. Okay, whether the delivery will be normal or cesarean will depend on the scenario at 37 weeks. Remember my dear student, if it is placenta previa, then we prefer to do LSCS, of course, because baby placenta फाड़ के बाहर नहीं आएगा. Okay, कॉमन सेंस कि अगर ये यूट्रस है एंड ये प्लासेंटा है और ये बेबी है, आई एम टॉकिंग एट 37 वीक्स, फटा प्लासेंटा निकला हीरो और हीरोइन, नॉट पॉसिबल. सो बेबी कैन नॉट perforate through the placenta and come out. So if it's a proven placenta previa at 35-36 weeks, then at 37 weeks before the onset of labor, we do LSCS. Here we in the question paper, we are only 20 weeks. So basically wait and watch. Repeat the ultrasonography at 32, 33, 34 weeks in the third trimester T3. Delivery normal hoga, vaginal section will be decided at the situation of the placenta in the before the delivery. And MTP, of course, there's no need to offer MTP or suggest even MTP for the patient. Okay. If the question was placenta is low lying at 35-36 weeks, then it is going to remain down only. If they tell you patient has placenta previa at 36 weeks, then at 37 weeks, sir, LSCS becomes the answer. So in obstetrics, weeks of gestation, very important. Don't make a mistake. Diabetes in pregnancy, called as GDM, gestational diabetes. What is the glucose load? Now please understand this. Multiple three things I'll cover for you so that you don't make a mistake. 50 gram is outdated. That was glucose challenge test. पुराने ज़माने में करते थे glucose challenge test where 50 gram load was given. And if that test was positive, Then proper 100 grams was given, and that is called as glucose tolerance test. In glucose challenge test, only a single value was taken. Glucose tolerance test, GTT, all of you know, my dear student, we take fasting samples, and then 1 hour, 2 hour and 3 hours. Okay, so totally 4 times the patient blood is collected in proper GTT. Sir, pehle fasting sugar, then 100 gram load, and then 1 hour, 2 hour, 3 hour. But all this is now not done. What we have to remember, my dear students, DIPSI, Diabetes in Pregnancy Study Group India. We follow nowadays the DIPSI guidelines or DIPSI criteria. I repeat, Diabetes in Pregnancy Study Group of India. Specifically Indian guidelines, where it is 75 grams glucose load is given to the patient. Fasting may or may not happen, that is fine. And just remember, after 2 hours, we take the lady ka blood sugar, and the blood sugar, what it should be, yes, remember the value, it should always be less than 140. If it is more than 140, directly we label the patient as GDM. Okay, I repeat, 75 gram glucose. So that is the answer, 75 gram glucose screening test. The screening test in India is also called as the DIPSI test. So much information you are getting just in this short video. Imagine when you go through the entire MCQ discussion video and the rapid revision package, you will become champions and master in OBGY is my guarantee. 75 gram glucose load देते हैं. After 2 hours, value should always be less than 140. Less than 140 is considered normal. If it is more than 140, then you label the patient as gestational diabetes. And the ideal time to do the test, anybody do comment in the chat box, do comment what is the ideal time to do the DIPSI testing. Okay, I'll answer it in the chat box. So all of you do comment in the chat box at what is the ideal time, at what weeks of gestation, when do we do the ideal time for screening in pregnancy for GDM. Moving on to the next MCQ. Gold standard or best investigation for endometriosis is. Now, endometriosis is presence of endometrium outside the uterus. Okay, it is outside the uterus. Okay, to confuse you, they might give you one more option, hysteroscopy also. Chalo, now tell me the answer. So please understand, ultrasonography or even CT scan or MRI may at the most only see a chocolate cyst. अगर chocolate cyst है तो वो USG में pick it up. Okay, but what, and chocolate cyst may not be present. So now please understand it. Seeing is believing. Seeing is believing का मतलब क्या है? Laparoscopy is preferred. And why? Because we can not only diagnose it, simultaneously treat it. So now all of you look on the board. What is laparoscopy? So through the anterior abdominal wall, we put in a telescope into the patient's abdominal cavity. Now what all will I see in endometriosis? All of you look on the board. This is the uterus, this is the uterosacral ligaments. Here we get the fallopian tubes. So seeing is believing. You need to see the endometriosis with your own eyes. And what all can we see? So we can see the ovary, and yes, ovary ke andar we can see the chocolate cyst. So that is correct. Chocolate cyst आपको दिखेगा. But anybody else? So one is the brownish blackish color chocolate cyst. Okay, I'm writing it CC, chocolate cyst. But anybody, can you tell me what else we see in endometriosis? Yes, fruit salad. फ्रूट सैलेड का मतलब क्या है? वी गेट रेड लीजन्स, रेड रास्पबेरी, पर्पल रास्पबेरी, स्ट्रॉबेरी, ओके, एंड यू गेट लाइक दिस ब्लू कलर, ब्लूबेरी लीजन. इट्स अ वेरी कलरफुल पिक्चर. So it's a blue color, bluish nodule. Remember this, bluish nodule, blueberry lesion. Also then you get purple. Okay, so it's a blue, पर्पल कलर के नोड्यूल्स we get, these are called as endometriotic implants. And do not forget, so कौन से कलर है? रेड रास्पबेरी, पर्पल रास्पबेरी, ब्लूबेरी, स्ट्रॉबेरी, ऑल दैट कलर याद रखोगे. एंड डू नॉट फॉरगेट माय फेमस matchstick burn or gunshot, which is black color. Okay, so everywhere in the pelvis, in the uterosacral area, you get this matchstick burn spots or powder burn spots. Okay, matchstick burn spots or powder burnt appearance or matchstick burnt appearance is all which is black, and also there would be adhesions in the pelvis, adhesion between the tube and the ovary. So all this we can only see with laparoscopy, and also simultaneously, not only for diagnosis, laparoscopy helps in treatment also. So laparoscopy is the best investigation or gold standard or confirmatory for your endometriosis. Hysteroscopy, my dear student, is to look inside the uterus for any cavity problem, for cavity. If inside the uterus there is a problem, then I use hysteroscopy. Endometriosis, everything is outside, so we have to go for laparoscopy. Moving on, yes, very simple, one MCQ on vaginal discharge and vaginal infection is definitely going to come. M-cells criteria. Anybody? M-cells criteria is for what? Yes, sir. M-cells criteria is for bacterial vaginosis or for Gardnerella infection. Anybody? What are the 4 M-cells criteria which we should know? Anybody? Yes. So the vaginal pH is generally more than 4.7 or 4.5. There is a grayish white discharge with a fishy or grayish white discharge. What else? Presence of whiff test positive. Very important. 1000 बार ये MCQ आया है और 1000 बार आएगा. Whiff test is you take the secretions, you add 10% KOH, vaginal secretions plus 10% KOH, we will get a fishy odor. That is the whiff test. And lastly, presence of clue cells. So all these are M-cells criteria which are given for Gardnerella infection or bacterial vaginosis. Okay. And remember one more point for bacterial vaginosis, partner treatment is not required. Okay, not required partner treatment because it's thought to be imbalance between the flora. Moving on to the next MCQ. Yes, image based MCQ. Anybody? What is this image? Okay, so again this is outdated. This was the first generation. अभी ये नहीं यूज करते हैं. First generation. This is Lippy's loop. This is a intrauterine contraceptive device. First generation devices. Lippy's loop. First generation मतलब के inert devices. All the copper containing, which contain copper, are called second generation, and hormonal ones are the third generation. Now clap if you feel happy. With this one MCQ, we are going to show you 4 images. Anything can be asked. Lippy's loop was asked couple of years back, तो ये plain याद रखोगे. Multi-load. How will multi-load device look like? Anybody? तो याद रखेंगे the sun rays appearance. This, my dear student, this is the multi-load device. Multi-load 250 or multi-load 375. Can you see this sun ray appearance? Sun ray का मतलब है कि in the school when teacher used to tell us कि draw a sun, हम कैसे draw करते थे? ऐसे. Okay, तो उसको ऐसा serrated fins है. Then vertical stem is there. On the vertical stem there is copper and there is another one more arm like this. Okay, so this is the multi-load device. Okay, Myrina, another name is LNG intrauterine device, completely white. White is white, no copper, no nothing. This has a hormonal barrel. Okay, so this contains LNG. Do comment in the chat box what is the total LNG. Total LNG मायरीना में कितना होता है? So this is Myrina, also called as LNG20. And why we call it LNG20, or we also call it as LNG intrauterine device. So this is a hormonal barrel which contains the hormone LNG. तो ये भी एक इमेज हो गया. क्लैप इफ यू फील हैप्पी. एंड लास्ट इज योर कॉपर टी 380 लॉन्गेस्ट एक्टिंग 10 years. ये लॉन्गेस्ट एक्टिंग है 10 years. कैसे पता चलता है सर? इट इज द ओनली वन वेर इवन ऑन द हॉरिजॉन्टल आर्म देयर इज कॉपर. सो कॉपर इज देयर नॉट ओनली ऑन द वर्टिकल स्टेम, इवन ऑन द हॉरिजॉन्टल यू कैन सी 2 copper sleeves. Okay, so we are seeing these 2 copper sleeves, and therefore we can identify that sir this is copper T 380. Details you're not supposed to remember, but this is 33 millimeter square area. So 33 का एक है, ये भी 33 है. Okay, 66 और ये 314 millimeter square. 66 plus 314 ऐड करोगे तो आ जाएगा 380. Clap if you feel happy. Okay, so with this one picture we have covered 4 pictures. Don't make a mistake. First one is LNG IUD Myrina. Second, multi-load device. Third one is the copper T380, longest acting 10 years. Okay. So my dear students, I'm so happy to announce the 1-month rapid revision plan, and more very, very important, you will be given free extension of your plan till the date of NEET till the date of FMGE examination. That means till 12th of January. That means if you buy the plan today, tomorrow, if you buy the plan on 1st of December, whenever you buy the plan, it is a 1-month plan. But whenever your plan will get over, don't worry, we will extend it. So if your plan gets over from 1st December to 1st January, 12 days, 2nd Jan, 3rd Jan. So don't worry, just take this 1-month plan. Beautiful, complete MCQ discussion video, superb. If this 45 minutes video is going to make a difference, remember, jab aap 16-17 hours, my dear student, just within 1 day, I just want 1 day of your time to maximum 2 days. OBGY is a major subject. All of you know 30 to 35 MCQs are going to come in FMG examination. 30 questions if you're lucky, 35 MCQs, and just in 1 to 2 days time, all the 16 hours, beautiful, all the clinical case-based scenario, must-know questions, PYQ, image-based question, and beautiful notes. The notes are so good, you can revise the entire notes just in 2 to 3 hours as per all students have told me, and get in touch with me. And this is only 570 rupees. It's like less than 300 rupees for gynecology, less than 300 rupees for obstetrics. Combined, the price is just 570 rupees. I repeat, this is the 1-month rapid revision course. The validity is 1 month, but all of you are going to get free extension till January 12th, till the date of your FMG examination. Don't forget to use this coupon code, and this is the final price what you pay, only 570. Beautiful notes, and of course doubt solving and my personalized timetable and guidance. I'm available on this number for helping you with your timetable. Do WhatsApp me and do call me on this number as soon as you see it. And look at what all the students have told me about the examination, sir. Everything that, sir, all the 30 questions in my paper were from your video lectures. Thank you so much, sir, for your wonderful lectures. And see the beautiful handwritten notes. So easy, completely colored, handwritten with all the integrated images you can see. Okay, so you can revise the entire notes. These notes are included. Okay, you can easily revise the entire notes in 2 to 3 hours after seeing the video. So maximum you are going to require only 1 to 2 days to master entire OBGY. These notes are included in the rapid revision MVP pack. So please do not waste time. Quickly subscribe to the 1-month course, and we'll give you free extension till the Jan 12th examination. And best wishing you all the best. And do comment in the chat box if you have any difficulty or if something is not clear. I'm there to help you out. Bye bye, best of luck, and thank you very much.